Good afternoon, everyone. I hope you all had a interesting lunch discussion. Welcome to session 3A, Community Partnerships for Climate and Health. I'm Yang Liu, professor at the Violin School of Public Health at Emory University. I'll be hosting this, I'll be moderating this session. We have 4 interesting talks. Each speaker will have 10 minutes and maybe a very quick clarifying question right after the presentation. And the rest of the questions will be handled during the panel discussion at the end of the session. Without further ado, our first speaker is Sheryl. Magzamen, yes, from Colorado State University. What's yours, Sheryl?
Thanks, Qian.
Just advance slides. I can do it for you too.
Good afternoon, everyone. Thanks for attending this session. Thanks, Jenny. And thanks to everyone who's joining us online. Yes. Okay, so this talk is meant to be an impetus for a discussion that hopefully we can have during the panel session. I'm really excited that. And I titled it The Academician's Code of Conduct, an Open Discussion on Community Engaged Research. And the premise here that I wanted to pose to everyone is, what are the most successful and ethical frameworks for academics to engage with communities for research with a focus on environmental health? And by practice, I'm a respiratory epidemiologist. And although there is extensive scholarship in this area, I'm really speaking from experience of being in the field and working with residents and thinking through things that have worked well, thinking about things that have not worked at all, and wanting to hear from the audience about questions and experiences you've had to add to this discussion. So like our panel talk this morning in this room, there are some motivating assumptions that are actually inspired by our site here at UW-Madison. So one of my favorite ones is the report out of President Charles Van Hise, who was president earlier in the last century of the university, talking about the Wisconsin idea. And the quote below says, the Wisconsin tradition meant more than a simple belief in the people. It also meant faith in the application of intelligence and reason to the problems of society. It meant a deep conviction that the role of government was not to stumble along like a drunkard in the dark, great metaphor, but to light its way by best torches of knowledge and understanding it can find. So that is often an inspiration for academicians to engage in community work, about that the university should not stand alone as an ivory tower, but really, especially our public institutions, promulgate the knowledge from the institution to the betterment of society. And the lovely plaque that's over on Bascom Hall, also to report to the, I think it's to the Board of Regents, whatever may be the limitations which trammel inquiry elsewhere, we believe that the great state University of Wisconsin should ever encourage that continual and fearless sifting and winnowing, by which alone the truth can be found. And I think that's really what motivates us as scientists, is the search of the truth. And now that I've spent 5 minutes reading that, I'll go to the rest of my talk. So when I'm at Colorado State, I teach an undergraduate class called Human Disease and Environment. And I'm going to present 2 articles that I assign my undergraduates to read. One is this article on the Flint water crisis from 2014 and profiled Mark Edwards at Virginia Tech. And the title of the article is Flint's Water Crisis and the Troublemaker Scientist. And I asked the students to read this article. It's really interesting. And I put the citation there in case you're interested in reading yourself, because it really helps us think about these key questions, especially about academics' role in community environmental health projects. So who speaks for the community? Not only the public facing part of community work, who speaks to the press or the media, but whose opinions and thoughts rise up to the top of the community to actually be expressed. Should academicians be invited into a community discussion, and who or where does that invitation come from? So in your work, how have you engaged with communities? Is that by introducing yourself, or is that accepting an invitation? For academic researchers, is there a continuum between scientific objectivity and advocacy? Often, because we work on environmental justice communities and environmental health problems, there may be a gray area of operation, and sometimes academicians, especially scientists whose mission is to be objective, sometimes that gets muddy the waters. And has that inflection point potentially changed throughout your career, or has it been the same throughout your career? And then what guides academicians' relationships with journalists? And again, I'll read a quote, sorry, very quickly. In 2011, the American Association for the Advancement of Science, the largest scientific society in the world, commissioned a paper on the standards, benefits, and risks of advocacy. When scientists become advocates, they become partisans and are no longer neutral conveyors of scientific information. While the line between neutral and partisan, between dispassionate and passionate is not easily drawn, it nonetheless exists. So remember, this quote is from about 10 years ago. Does this still stand today? And Mark Edwards was quoted in the article by saying, as a result, the idea of science as a public good is being lost. And I think given our current political context, I think like many of us are feeling this. And along with it, the symbiotic relationship between the scientific community and the public. So there's a couple lectures in between. Then I assigned this article, the 18 twitching teeth. And upstate New York community, there was a mass psychogenesis event, an origin. This came, I think this happened in 2012, trying to understand why these women were experiencing tics and other really interesting case studies. So some of the key questions in the article: how do we talk about disease etiology with communities, particularly for complex chronic diseases and complex multimodal exposures, as we talked about previously? How do members of the scientific community work with each other rather than following discipline-specific leading hypotheses? And again, I want to note this is distinct from public health officials who have direct responsibility to the communities. How do we disentangle the contribution of community social factors and environmental exposures that coincide and both contribute to disease, particularly in EJ communities? And how do we evaluate and consider the roles now of social media platforms for leading hypotheses to get community buy-in? So a quote from this article I want to share: that so many people in town were more preoccupied with environmental waste than the homes of the affected young people suggests that their message may have been hard for some of the adults to hear. So what if we have news that people don't want to hear? So the motivating question, and I'm excited for our panel talk, is what are or should be core operating principles for academicians to engage with communities for environmental health research? And what are your guiding principles? So the food for thought I had, and inspired by lunchtime, so thinking about knowledge exchange rather than knowledge transfer, this idea that we can garner information from the community and not only be people that deliver information to the community, that there's community-based knowledge that is mutually beneficial to our work. Working with trusted partners in this community, and these are gatekeepers or people that extend invitations, but often sometimes we work in communities where we're not members or residents. So idea that who can vouch for us, or do we need to prove ourselves to make sure that we have community trust? A strong specific description of a rationale for doing your work. In a recent community engaged project, we got questions asked by the community: why are you here? And why do you want to do this work? And that's very important to have a good answer to that. And then what do you do when things get complicated? And that's been inspired by our HAQAST Tiger team. So this is an article that appeared in the Palm Beach Post talking about the smoke that comes from sugarcane burns in South Florida. This was a very well-documented article where the researchers even used satellite imagery and purple air to actually understand the smoke plumes that are in the Everglades agricultural region. So that article is not the only narrative that's going on in South Florida right now. There's another narrative that's being promulgated, which is leave us alone. We don't want people coming in and telling us what to do or how to behave. We don't want health people interfering with our decisions about how local economy is run. And really that countervailing narrative is important. People are very scared of losing jobs or having changes made to their community without their buy-in. But these two narratives are in contrast together. And it's very challenging because, like many things, this issue has really polarized the community we're working in. So that's just an introduction to some of the issues that I'd love to talk about as a panel, and just wanted to say thanks for the invitation and the time.
Thank you very much, Sheryl. Our next speaker is Shaneeta Johnson from Morehouse School of Medicine.
Good afternoon, everyone, and thank you very much. Not in the right spot. All right. Good afternoon. Thank you very much for the invitation to be here. I have really enjoyed the discussions and the presentations. And so I'm a surgeon, and a minimally invasive and bariatric surgeon, and involved in this work. My topic is story mapping the impact of climate change on health. I don't have to tell you in the room that this is a public health emergency. that this emergency also disproportionately affects some communities. We know that there are significant costs associated with climate change. And then in the healthcare field, we see significant deaths and morbidity. And when we look at healthcare systems, all healthcare systems are not equal. And so those with weak health infrastructure are least able to cope and to mitigate the effects of climate change. I like this slide that talks about the impacts of climate change and exposures and its impact on health. And, there is this very broad impact on health. When we talk about air pollution and we look at asthma, cardiovascular disease, and other respiratory diseases, we talk about water quality impacts and infectious diseases, extreme heat and heat-related illness and death, environmental degradation, forced migration, and its stressors upon a health system. So we know that increasing temperatures can cause poor air quality. That causes cardiovascular disease and pulmonary disease. Flooding contaminates water. Severe and extreme weather events can cause injuries, deaths, illness, migration. Extreme climate events stress an already stressed system. So our health system is under stress, as you know. And then when we talk about our most vulnerable populations, I've listed some of them here, but these are not all. So our kids who are playing or practicing their sports in warmer and warmer temperatures each year. Those are pregnant, elderly, those with chronic illnesses and allergies, and of course, those with limited resources who may not be able to move to avoid some of the effects. This is a really good slide from HHS that talks about the climate drivers, the exposure pathways, but I like the two sides. That even though we may all have the same climate drivers and exposure pathways, our environmental and institutional context and social and behavioral context may vary the amount of effect that we see. So things as ecosystem change or our geography, are you in a rural environment or an urban environment? What's the poverty level and the housing infrastructure where you live? Education and discrimination. And these have an impact on our health outcomes. We see direct physical effects of climate change, cardiovascular disease, pulmonary disease. We see disruption of health services, stress, anxiety, depression, failed crops, and malnutrition all have an impact on the health of our population. And nowhere in the US is spared. So from Hawaii to Alaska to Maine to Florida, we are all impacted in various ways. While climate change is not spoken about in the medical profession the way we should, we are aware of the impacts of climate change. This is a survey that I sent out last year looking at African-American physicians and their views on climate change. And you can see that the vast majority felt that climate change is harming their patients, them personally, the folks in their community, and certainly future generations of people. I'm a surgeon, so I have to put in a slide or two on surgery. So climate change does have an impact on surgery. It affects the preoperative care or perioperative care by affecting the frailty of our patients. So our patients come to us with the burden of cardiopulmonary disease. They're sicker when they see us. We see adverse birth outcomes. We know that climate change impacts preterm birth on the level of 2 million preterm births per year. We see increased trauma burden from flooding, from heat events, from natural disasters, relocation of population and health services. And of course, we are burdening that already burdened health system. And we are contributing as well. So the healthcare system contributes about 10% of US greenhouse gas emissions. And so we really do need to work more. Congratulations, Dr. Holloway. I know that NAM has a task force. I'm on the task force that's looking at decarbonizing the US health system. We need data. And so I'm glad to be here amongst all of you to see if we can partner to get data. We need data that is going to translate what we're seeing with climate change, air pollution, heat indices, and so on into health so that our communities can understand very easily the impact that climate change is having. Because if we don't, we're going to see an inequitable and inadequate response. And we want to make sure that all communities will be able to mitigate the effects of climate change. I know that we have an environmental justice panel tomorrow. So just a slide or so on that. We know that certain communities are more likely to be negatively affected. People with disabilities, the LGBTQ population also have a higher tendency to be affected. Heat islands, more common in urban areas. A higher percentage of Black and Hispanic people are in the US South, Southwest, and West, projected to experience more extreme heat. We know that factories are more likely to be in poor and underserved communities. They're more likely to live near highways. And this all is an unequal response. And so what we'd like to do is look at developing a data infrastructure to address the health equity impacts of energy use and climate change. And this was started as a challenge. This challenge was in May with the US Department of Energy, New York Power Authority, and ourselves. And this was a selected obstacle. We want to look at data infrastructure to address the health equity impacts of energy use and clean energy implementation in communities of color, at-risk populations, and accelerate STEM. We have a task force that is a national task force. A lot of folks involved in this field that are excited to work on this. We have started partnering with different organizations. We partnered with Esri. Esri is the force behind data mapping for COVID. So those graphs that came out of Johns Hopkins were put forth with data from Esri. The American Association of Blacks in Energy, Novartis's Beacon of Hope, the Health Equity Tracker, which has already been put forth, looks at things like social determinants of health, able to drill down to insurance availability, COVID, diabetes, as well as mental health impact. These are some of the variables that we would like to look at: air pollution, natural disasters, heat index, and then we'll overlay that with maps looking at lung cancer rates, with maternal mortality, preterm births, respiratory illness, emergency department visits, food quality, water quality, heat stroke, housing infrastructure, proximity to factories and energy, and then social vulnerability index, demographics, and geography. Initial cities: Atlanta, Boston, and DC. And so this is just an overview of what we would like to get to, is to be able to tell the story so that the health professional can talk about it in their office, and that those in the community can understand what their risks may be where they live. And so this is one that Esri has. This is a COVID one that can look at health insurance coverage, can look at poverty, at-risk populations, can drill down to your county and your zip code. And we'd like to see that in the space of climate change as well. Thank you so much.
Thanks a lot, Shaneeta. Our next speaker is Dr. Qian.
All right. Good afternoon, everyone. So I guess what my talk will be is going to be a little bit different from the broad perspective that the previous two speakers gave you. And now I'm going to give you a more sort of narrowly focused talk, which is on light at night. That's what I study. And hopefully, I think what I'm hoping to achieve is to give you sort of a concrete example or a case study in which I want to talk about how we evaluate the current research evidence and how we set future priorities, not just in terms of scientific rigor, but also practical and translational implications of our research. So, oh, that's my. Just a little bit outline. As I said, I'll talk about the current evidence that link light at night as an emerging environmental hazard to health outcomes. I'll talk a little bit about methodological considerations when we evaluate evidence, and also present evidence from our own research, and then talk about future directions, both in terms of research and other action items. So first, let me give you a little bit of background about light at night. You probably have seen this picture before, but that's a nighttime satellite image of this country, and it shows all the bright spots, which are where we experience a high levels of light at night. I think it's fair to say that we are all experiencing a high levels of light pollution due to the highly prevalent use of electric lighting. A key challenge to public health or to human health in modern world is that really we're experiencing too little light during the day because we're staying indoors even in a beautiful day like today. And we're experiencing too much light at night because we're looking at our screens and turning on TV and just using all the lighting in the indoor environment. And when it comes to the light at night exposure patterns, there is dramatic variation, both in terms of spatial distribution of light and also in terms of temporal trend of light. So there are hot spots in this country where experience high levels of light at night, and also places where there is a rapid increase in light at night. And when we consider the driving factors of such patterns, of course, there's the usual suspect of economic development, and I'm sorry, that should be population growth, not GDP, which is repeat itself. And also there's other correlations between light at night exposure and other neighborhood characteristics, such as the social demographic and the social economic characteristics that will have an important environmental justice implication. So the first thing I want to talk about when we evaluate the current epidemiological evidence that link light at night with health outcomes is really the methodological considerations, right? And the first thing I want to talk about is how do you measure light at night? Because that's really important when it comes to studying any environmental hazard. When you look at the current epidemiological studies, the various methods for measuring light at night really fall into two categories. The first is personal level measure, where you can ask people about how bright their bedrooms are or their home environment is, or you can have more objective measure where you can use a photometer. It can be a stationary photometer that can be placed on their nightstand beside their bed, or it can be a wearable photometer that measures light levels. The first type of measure, their self-report, is really not very accurate, where the second type is more accurate, but it's very hard to scale up in large epidemiological studies. And that leads to the second type or second large type of measurement, which is based on satellite data. And the benefit of using satellite data is it has great spatial and temporal coverage, as we all know. So it's very suitable for large epidemiological studies. It's publicly available. However, I should mention that it does require you know where to access the data, and you need some GIS expertise to process the data and link with the data set that you want to use. Another caveat here for using satellite measurement is really there is a huge debate out there whether the outdoor satellite-based measure of light at night can actually reflect personal exposure. And we can talk about that as a research objective later. And then just quickly go through this. There are different types of study designs that you can use to look at light at night. There's the ecological study where the analytic unit is not individual, but county or tract level data, cross-sectional study where you measure light at night and health outcomes both at the same time. And prospective studies, really what I'm going to use as an example here, where you first measure light at night and follow people up for health outcomes, which is also considered a stronger type of study design. And finally, there's what I call natural experiments, where you take advantage of the changes that's naturally occurring in the world. So there will be changes in light at night, and you really try to evaluate how that change may have an impact on health outcomes. So there are large cohorts. That's the third type of study I just mentioned there that have address information, which you can use to link with environmental data, light at night in this case. And the benefit of using large cohort is that they have various health outcomes. They have rich information on other social demographics, lifestyle, and health related factors. So we can use the data to study many different types of outcomes and control for confounding. They have varied protocols for accessing their address information because of confidentiality concerns. So that's one thing you need to consider when you use that type of study. But there's growing interest. I guess that's the good news that for using those large cohorts to look at light at night. So this is the one example I want to talk about today. This is a large study called NIH ARP Diet and Health Study, which is a study that I just happen to know very well and use their data a lot. So this is a very large cohort. At baseline, they have 500,000 men and women in this country, and they have their address information, which is ideal. So I can link that to light at night. And they have follow-up both cancer outcomes and also for mortality outcomes, including cause of death. And it's still ongoing. The baseline was in 1995, so it's still an ongoing study with continuous follow-up. So showing here, don't know why the sleep deficiency get duplicated, but there are 5 health outcomes that this is taken from published paper that we did in this cohort, where we looked at the relationship between light and night and various health outcomes and sleep deficiency, obesity, and risk of 3 forms of cancer showing on this slide. So basically what you see here is on the x-axis, you have light at night from the lowest to the highest level. And you have various health outcomes presented on the y-axis, and you can see all the lines go up, indicating that the higher levels of light at night you have in their linked with their home address, you have higher prevalence of sleep deficiency, no surprise there. You have a higher risk of developing obesity. You also have a higher risk of developing postmenopausal breast cancer, pancreatic cancer, and thyroid cancer. And by the way, if you're interested in the original paper, you can simply Google light at night and those health outcomes and the study name, and you will find the published paper. So there are many other cohorts. I'm just giving you some examples there that have already been linked with light at night information. And there are other health conditions that have been linked with higher levels of exposure to light at night, including mental disorders, diabetes, and mortality. So it's fair to say that currently we really have convincing and growing evidence showing that light at night is an environmental hazard that has a wide-reaching impact on many health outcomes. So now I want to talk about the research gaps and the opportunities, which hopefully really serve as a discussion point that we can go into this a little bit further because I know my time is up. So first, we need more study in more diverse population. Most of the studies that I mentioned are conducted in predominantly white and high SES population. And we definitely need more diverse cohort, more diverse study sample to look at some more disadvantaged populations, and also to study more health outcomes. I mentioned the measurement validity, which is really important. And I think it's definitely a research priority to assess how well the satellite-based measures can actually reflect personal level exposure to light at night. And we should assess validity, not just the overall validity, but also according to different population characteristics, according to different geographic locations, for different health outcomes. And I'm mentioning enhance here because it's one example where both satellite information can be possibly linked with the data, and also individual level measure is available. So you can potentially assess validity in that study. And also we need to know how individual and neighborhood characteristics can modulate the effects of light at night on various health outcomes. We need to understand the determinants of light at night exposure patterns. What are some factors that lead to a high levels of exposure and possibly the adverse health outcomes related to light exposure? And finally, we need to assess the impact of changing light at night exposure on health outcomes. So what would be the impact of changes in lighting policy? What will be the impact of changes in lighting technology, right? For example, there's more and more use of LED, which is more blue enriched light, which can potentially have more adverse health outcomes or health impact on human populations, and something that we really don't have a lot of study for. So this is my final slide, and just thinking about, setting priorities for not just research, but other action or public health or policy related actions that can actually have an impact on public health. So how do we incorporate light and night in mapping tools? I don't think there are a lot of mapping tools out there that has light information, and we're trying to change that. How do we conduct public health surveillance for health outcomes that are related to light at night in communities that are exposed to high levels of light pollution? Public education, right? How do you change the public perception? Maybe some of them are not scientifically based about the benefits and harmful effects of light at night. And finally, how do we impact public policy? How do we impact lighting policy? How do we influence urban planning? Hopefully, both of which will lead to a smarter lighting solution to our society. So that's really all I have. Just acknowledgements. Do we do questions or? Sounds good.
Thanks a lot, Qian. Last but not least, Mitra Kashani from CDC.
There I am.
All right. Hello, everyone. My name is Mitra Kashani. I am an ORISE fellow at the Centers for Disease Control. They're the CDC tracking program. And today I'm going to be talking about how we are working to advance data and tools for climate, air, and air quality and health. So I'm going to do a quick little introduction to the CDC's Environmental Public Health Tracking Program. And then I'm going to highlight some of the different partnerships and collaborations that allow our work to be possible. So our main goal at the CDC tracking program is to connect environmental information and health information all in the same place in a way that's accessible and that's easy to access. And so we cover topics from environmental hazards and exposures to health effects and population characteristics. And some of the topics that we cover are highlighted here. And I'm going to be focusing a little bit more on environmental justice, air quality, and emergency response for today's talk. So we disseminate our data in a variety of ways. Our flagship product is this interactive data explorer. So that includes over 700 measures, which is a lot of data that users can access. Again, it's publicly available, and users can access this through a variety of data visualizations, including choropleth maps. You can also transform that data into tables and charts to fit your needs. That data is downloadable. You can also export it, export images and all the other data visualizations. And there's also the possibility, we have a feature that allows our data visualizations to be embedded in your own websites or programs as well. There we go. Thank you. We also have a variety of dashboards, and the dashboards focus is to focus on a very curated specific topic area. So for example, environmental justice or heat and health, both of which I'm going to touch on today. And these allow users to explore local level data for, again, this very hyper-specific curated topic. It includes a variety of visualizations and measures to explore data at local levels. And then finally, we have our own application program interface or API. So for those that are more into development, you can use that to embed or pull in any of our data into your own applications. And everything I'm presenting today and all the work that we do at CDC Tracking wouldn't be possible without a variety of collaborations and partnerships that we have fostered over the years. So Within our team, we're working with science communicators, we are working with IT and data visualization specialists, science educators. We're working with kind of a broad array of collaborators internally, but also externally. So we partner with a lot of other agencies and then also local, state, and national level partners. We also fund recipients through a cooperative agreement. So these are local and state health departments, including Wisconsin. So overall, this year, we have 33 recipients that we fund. And our main goal with this is to help them bolster and create and develop their own tracking programs so they can meet the needs of their states or their localities. And we just provide the support for them to be able to do that. So I'm going to talk a little bit again about some of the dashboards and different preparedness tools that we have around climate and health and air quality. So the first one I want to highlight is the CDC's heat and health tracker. So this dashboard essentially allows users to explore different heat risk, vulnerabilities, and exposures, again, at local levels. So you can enter your zip code or county and explore the different risks and exposures for your locality. So this can be used to inform various public health actions at the local level, and you can use it to identify when and where to activate and close cooling centers or describe extreme heat trends. You can also describe and locate vulnerable populations, which we can see on that those bottom 4 panels. Those give some population characteristics and descriptions that can inform where the most vulnerable communities lie within the region of interest. And so for this, we've partnered with CDC's Climate and Health Program. So that's our internal partner, but we've also worked with NIH, the National Weather Service, the State Mitigation Hazard Office, SHMO. I don't know if I use that acronym correctly, but we have various external partners that helped us develop this heat and health tracker. The other dashboard that I want to highlight is the environmental justice dashboard. So this again allows users to enter their county or city or zip code to explore environmental justice related measures and social vulnerability measures, again, relevant to their locality. So I have Wisconsin, Dane County specifically highlighted in this image, but this also allows users to explore, again, those different social vulnerability and environmental justice measures. It provides various infographics and data visualizations, and also highlights some of the different social vulnerability and community characteristic attributes as well. Also, we focus a lot on preparedness resources. So being able to understand the vulnerabilities of communities during an emergency, a health emergency or natural disaster is very important. So we try to have these data ready as well. And we have a Data Explorer variant that is, again, curated to house these like emergency response data sets. So for example, they'll highlight different community characteristics, populations, and vulnerabilities. And then for certain emergency response needs for flooding or precipitation, extreme heat, we have curated data sets that will allow users to explore the needs for local communities. And for this, we have partnered with NOAA, we've partnered with EPA, and other external partners to help pull that data in and disseminate it to public users. And then finally, air quality. So air quality is one of the content areas on our tracking dashboard. Again, I just have an image of Dane County, Wisconsin highlighted here. But this is where we highlight, this is one of our content areas. And we include forecasted air quality data, monitored and modeled data as well. And the one I'm highlighting on this image is forecasted air quality data from NASA GEOS. And so this will allow users to get daily kind of understanding of the local air quality in their region of interest. And with that said, I wanted to highlight maybe for a later discussion with folks in this audience, some of the data challenges that we face, especially with satellite data. So we know that many satellites aren't doing a great job estimating surface level pollution. and they're mostly tropospheric. So we're wondering if that's a good enough level for estimating what people are breathing and the potential health impacts. And then there are hyper-localized disparities in air pollution within communities too. And so we just want to be able to see how we can meet some of those data gaps. And then questions for this group, and we can return to these later, are, how can we leverage at the CDC some of the partnerships across climate and health? So I see a room full of potential partners here. How can we leverage those partnerships to build better, more informative data networks? Where does satellite data fit into the tracking network? And what types or topic areas can you all think of that we can take a look at CDC tracking and help pull into our data explorer? And that's all I've got. Thank you.
Thanks a lot, Mitra. I'd like to invite all the speakers up front, and let's start our panel discussion. Okay, audience, feel free to ask questions. Okay. Oh, Tracy, does your the buzz thing, does that work? Can you try it?
Oh, wow. Okay. Thank you. Hello. Thank you all for your talks. Really interesting and nice to come at it from different perspectives. I was curious about sort of matching the needs of different communities to find data with the data platforms that already exist, and then the platforms that don't yet exist. And I guess, I'd value all of your perspectives on how well do you think that existing data platforms are being utilized, and how well are community groups being empowered to navigate the abundance of data sources that are already there, and where are there new needs? Because, as researchers, it's very tempting to say, well, we need to build a new website, a new portal. But actually, there's already a lot of portals, including through the CDC and through EJ Screen. And, something that, I think is really at the heart of this is how well are they being utilized and where are the barriers? Thank you.
Is this on? Can you hear me? I have a loud voice. I think that goes to the heart of it. And as we started our project, we realized that there are a lot of existing platforms. We just were unaware of many of them. And maybe this is an opportunity to marry several of them to get the information that we are particularly looking for. So we would like something that's very patient-facing, so that the patient can walk into the office and get that information and be armed to educate their own communities that I have a higher rate of, or a higher potential incidence of lung cancer because of these climate effects, so to have it very, very accessible for the patients. And so I think that means probably not reinventing the wheel, but using the wheels that we have and putting them together in a different way.
Yes.
It was on. Good job. Yeah. Tracy, it's a great question. I think that there's some tools that have become more user-friendly, especially around air quality, like the AQI. We just did a community training where sometimes it's really difficult to not only explain what PM and ozone are, but then what the measurements mean. But the color coding of the AQI and the messaging that comes along with that is incredibly community friendly. So maybe we're skipping a couple of steps going from what we talk about in our scientific communities to what goes on at the community level, but that's been really effective. And I think that's a great model. But we've also found that some of our projects don't really address community needs. For instance, I know we've talked a lot about potentially comorbidities or co-exposures. And we are working in a community in Denver right now that has a lot of concerns about odor, in addition to air quality and heat and traffic and noise. And there's just not a lot of odor research out there. So I feel like, as a scientific community, we focus on not a conscripted set of issues, but issues that also, I think, engender potentially policy and change. So we have to realize that we have multiple audiences, and some of our quality life issues, which we know deals with stress and potentially other chronic diseases, aren't being well addressed in the scientific community. So I feel like there's some real gaps in that. And I think we have to be creative about how we address this.
I can also add. Yeah, I mean, one of CDC tracking's primary aims, one through supporting different state and local health departments, but also through our partnerships with other agencies, is to eliminate some of those data silos, because we know that we're all building these really cool portals and indices and dashboards, and like it's all happening. And for an end user, especially in like local communities that benefit most from the tools that we're trying to build, how do we communicate where they go? Like, where do they get their data? So I don't have an answer right now. That's something we're definitely still figuring out, but it's kind of front and center on our minds for sure.
Jonathan, can you press that?
Yeah, so I have two questions. These are great presentations. Sort of tagging on to this last one about data and with the environmental health tracking, I'm wondering if you're bringing in something called the Neighborhood Atlas with the Area Deprivation Index. It's trying to get at equity across neighborhoods at the block level, census block level. That's one question. And then a second question for Qian. You know, of course, there are all the confounding factors with night lights, and night lights as an indicator for some other exposure. And I'm wondering, what is the biological plausibility pathway aside from the effect of light on melatonin? What is, you know, is light just a surrogate for all the other exposures, or is there a real biological plausibility? So two questions.
I can go first. Neighborhood Atlas, I'm personally not familiar with it. I don't know if anyone on my team, any of my colleagues are on the Zoom call that are familiar, but that is definitely something I will look into. And then we also, I forgot to mention, we want to pull in light at night data too.
Yeah,
for
we're
tracking.
working on
So
that.
we're working on that.
Yeah.
But yeah, I'll pass it on.
We
Yeah.
have been looking at the Neighborhood Atlas, so that's one of the data platforms we're looking at.
Did you know it's developed in the process?
No, but I know now, so I will make sure the team knows.
Yeah, so I also want to address the first question as well. So that I think it's a ADI for short. That's actually something I have used in my own research on neighborhood deprivation. I think it's an index that's widely used in public health where people focus on neighborhood deprivation, but I think it's still a sort of emergent thing for environmental justice for people who study environmental exposures. So I feel that's why this type of venue is so important, because that bridges people from different fields together. I also want to add that the CDC has the social vulnerability index that has some similar information. Also, it's an assessment of the social, economic, and it has 4 different dimensions. So that sort of the deprivation theme is in that measure as well. So just like the different platforms that we have for environmental exposures, there are also different index that people are using for the more social economic aspect of neighborhood, and it's a it's a huge research area as well. And now address the second part, which it's but I didn't have time to talk a lot about this, but yes, there is a very strong biological plausibility why light at night may affect health, and this is through the 24-hour circadian rhythm that we all have, right? We have this so-called biological clock that was evolved as a universal adaptation to the 24-hour light-dark cycle on our planet. And that's something exists not just in humans, but in bacteria, in almost all life forms on Earth. And if you disrupt that environmental cue for setting our clock by having too little light during the day and too much light at night, that disrupts our circadian system, which lead to sleep deficiency, which lead to metabolic disorders such as diabetes and many, many other health consequences. So in short, yes, there is a biological pathway and there are biologists that are working on that in lab animals demonstrating that's a real thing. However, I do think the point you mentioned about the correlation between light at night and other environmental exposures, especially other urban exposures that are highly correlated with light at night, is an important consideration, part of the methodological consideration that we as epidemiologists need to take into consideration in our research.
Okay, let's go to this side of the room first. Amber?
I think that this could be a question for all of you, but it was motivated by Sheryl. And it's one of trust of the medical community and trust of scientists. And sometimes mistrust is because it's intentional, because a business is motivated, and sometimes it's not intentional. I'm not sure what it was, but it's really difficult to deal with something if you're not even trusted, your data or your opinion. I don't know if you want to give specific examples, but hopefully some of success. Like, how do we work with this?
I think you hit a very, very important problem. And so we can do all of the work that we do, have all of the fancy data sets, but if we can't get it into the communities to influence change or get it to the policymakers and have them trust the data that we are presenting, we're not going to make the difference that we need to. I think we engender trust by being involved in those communities longitudinally, not popping in and out. And so it's very important to develop those trust relationships over a period of time. And so part of that Health Leadership Institute that I'm a part of that is the community partnerships that we have to make sure that we've engendered that trust.
Amber, thanks for the question. And it's something that we grapple with all the time, being on the ground, being in the medical community as well. I think that part of that is just being very clear about our motivations. And when a community member asks us why we're here, to be very clear about why we're here. And for me, I'm lucky to be at a land grant university where that's part of my job. So I get to tell community members, I'm here because it's my job to be here. Bonnie Ford, who's on our HAQAST team, also talks about the idea that in science, we have gaps in knowledge. And we need to talk about, if we have those gaps, how do we fill those gaps? And how do we participate in a narrative if there's only data on one side or where that data comes from? But I think that we're living in a very fractious information world right now. And this is something we all grapple with, about where we get our information, where trusted sources of information is, and how that the lens through which we're looking at the information, especially if it doesn't fit with a worldview that we have. And we know that especially for historically marginalized communities, that mistrust has been, there for generations. And I don't know if we've done enough healing to figure out how to bring scientists and communities together again, especially in communities that bear the disproportionate burden of adverse environmental exposures. So I feel like as a community, having a real conversation about that is important. But I think for personally starting with a very clear motivation that I could talk about why I'm in a community, especially one that's not my own, is I think a good first step.
Thanks. I'm going to comment on that as well before. So I really like Shaneeta's idea of building trust in a longitudinal fashion. Parachuting scientists into a community doesn't work. I think a lot of the underserved, underrepresented communities are numb when you just come in and say, I'm here to help. That's not helpful at all. You can trust me on that. So yeah, it takes a lot of time to build that trust, and then it takes even more effort to maintain that level of trust, because that trust is very fragile. Okay, on with other questions. Front row, please.
I have a question for Dr. Xiao. Thanks for sharing the research about light at night. And during your presentation, you showed a very pretty map of the light, the US map. My question is, well, satellite can monitor the light. But that's not the exposure we received. For example, 2 weeks ago, I just bought a new curtain. So how you solve this uncertainty in your research?
Yeah, well, I think that's one of the main thing that I want to mention in today's talk, which is about the validity of satellite measure of light when it comes how well or how poorly it reflects personal level actual exposure to light at night. And you are right that it can vary for different individuals, right? For a person who has a blackout curtain, maybe there's very little influence from the outdoor light that can be measured by satellite. However, for a night shift nurse who venture out of her room and actually get exposed to all that night light is different. Or for a poor family who can't afford that blackout curtain that has very crowded living conditions in their homes, that can be another thing. So one thing we actually notice in our research is that the effect of light at night tends to be stronger in poor neighborhoods, right? So if you look at the relationship between light at night and say breast cancer, when you look at more affluent neighborhoods, the association is small, it's pretty flat. And when you look at that in the poor neighborhood, that association is much stronger. And we suspected that there could be a resource reason that they don't have the resource to mitigate that makes the outdoor measure, satellite-based measure more accurate. It can also be that they have other factors that actually exacerbate the effect of light at night. So which I think overall, what I want to say is it's very important to do those validation studies, which we actually do plan to do in a large scale population and more diverse population. And B, it's really important when you study health effects of certain exposures, thinking about other factors that may modulate the health effects of certain exposures, because when two individuals are exposed to the same thing, they may not develop the same problems because of the other things going on in their lives. So thank you for the question. Very helpful.
See another hand.
Yeah, thanks all for your perspectives. I'm Mindy from Environmental Defense Fund. But going back to what someone asked earlier, and also Sheryl, just what to do when things get complicated. You know, I loved the knowledge exchange, and I think there's a trust exchange too, going back to the previous question. But specifically what we've been grappling with is in our partnerships with community groups that we're starting to establish and work really closely with. I think they're going really well. And then we get to what to do when there are other priorities. So, you know, the majority of the groups that we're working with, even if the air quality, and they know the air quality is not good, and they know that most of the kids in their community have had asthma, you know, they're worried about so many other things. And so I'm wondering what your thoughts are on, you know, not abandoning, right? We can't abandon the community because it should be this longitudinal relationship, and we don't have the expertise per se in some other areas, or we don't have the resources, or we just can't address some of the other more pressing needs. So I'm curious on what your thoughts are on balancing this longitudinal relationship and other realities that we may not be seeing in our small world.
That's a great question. And I'm reminded of an anecdote that Len Syme, who's a professor of social epidemiology at Berkeley, had once shared about doing a research project with muni bus drivers in San Francisco and talking about their challenges and their struggles at work. And the whole motivation was, well, do we need to change your chairs? Do they need to be more ergonomically efficient? Do we need to make them more comfortable? And I think as it turned out, they needed bathroom breaks and places to safely go to the bathroom. That was the priority. And I think that the way, you know, we as academicians and kind of community partners are funded and we think about science often does not align with community needs. So I think one of our jobs is to be flexible. And sometimes I think of ourselves as technical partners. So thinking about, you know what, I don't have the answer for you, but I have a colleague, I know someone at another organization, and creating that ecosystem of technical help that can really bring in people that, yeah, I know about that and I can help, or there's someone at the health department or environmental public health tracking that works on that problem. So I feel like, we've experienced that so many times during COVID. We had this huge total environmental exposure project working with the state here, and COVID happened and the project did not go as planned. And that's frustrating. It's frustrating to us on the scientific side because we want to write papers to make sure that we're worthy investments by the funding agencies. And sometimes it doesn't happen. But I think stepping back and allowing communities to express that need, and also being resources as much as we can, even though that may diverge from the questions that we have or the guiding principles of our organizations, I think that's part of what being a good partner is. And we try to do that as much as possible.
Yes.
Question for Shaneeta. You talked about all the partners that you have together to tell those stories around climate change. Have you done anything on what stories actually work best? Have you found anything? Because I'm still looking for that, of what stories work best to tell the impacts of climate change on our health. Is it at the physician level? Is it at public health, or how? I guess that's like multiple questions there, but.
I think the stories are going to vary. So I think in the physician's office, that story is often asthma. In the pediatrician's office, that's a very strong story there. Then in the adult office is cardiovascular effects. That's a very strong story. And cancer, is very, very strong. So I think it's going to vary. In the community, they're concerned about infant mortality, preterm labor, asthma in their kids and their kids going to school, heat impacts for their kids practicing football in the summertime. So I think it varies. So we have to be able to be flexible and be able to project several stories, but we need to get the conversation started. I'm embarrassed to say that most of my physician colleagues do not discuss environmental impacts at all. When I see the American Cancer Society agree, it is a void, and it's a problem because this is an emergency. It's a public health emergency, and once we start talking about it, most physicians come on board and they understand the impact, and they want to make sure that the patients and the community are well versed. But I'm sure you're seeing that also. We just do not talk about it. We talk about your diabetes, your hypertension. We don't talk about, is your heart failure related to the heat waves that we've been having recently? Is the asthma that you have related to the particular matter in the environment? We don't make the connections, and we need to.
Jonathan.
Just add on one thing to Shaneeta, because I noticed that you're working with, in that paper, collaborators with the Medical Society Consortium on Climate and Health. And these are communication scientists that have done surveys of America, and it's called the 6 Americas survey. There's 6 different attitudes. But another study is who are the most effective messengers. And it turns out that the most effective messengers are nurses and doctors. So there's a huge growing movement, and I could see you're working with them. And I saw Mark Mitchell also on your collaborator. It's a very rapidly growing area in the medical mainstream medicine to get those messengers out there. So they're also trout fishermen and talking about trout dying in the heat. So it depends where you are. As you mentioned, very diverse stories.
Yeah, so just following up on that, I was kind of wondering if you had any tips for how it's one thing to sort of convey, like, here's these environmental problems you have to worry about now. And I imagine, like, especially if you're telling a patient who's recovering from surgery, they've got a lot of things to worry about. How do you convey it in a way that they feel like they can take effective action and do something with that knowledge rather than be weighed down by it?
Making it real to the patient. So, describing how climate change is impacting their health and then giving them concrete ways that they can make an impact in their own lives, looking at their energy use, other ways that they can make a small change, but they feel that they're empowered and they're making a difference in the climate change dilemma is key. I find that patients are more ready to hear this than we think. So I think a lot of physicians and nurses feel like, I can only talk about the diabetes and hypertension, but if you open up and start to speak about the rest of the impact and look at it globally, they are ready to hear this. And they know about climate change as wildfires and hurricanes. They've not thought about it as it impacts their health. And so they're ready to make that link.
Any other questions? Yes.
This is such a nice discussion. Thank you all. And I think just building on this question of how to communicate something in an empowering way and the AQI as an example, I mean, I think that there's almost like different categories of messaging, and one are the interventions that someone can take to protect their own health, and the lights at night is a good example, like putting on blackout curtains. And then there's the things you can do in your own community. And in some cases, that's targeting a specific emitter or pollution source or the community lighting, outdoor lighting structure or something like that. And then there are these broader issues like climate change that, you can give them the feeling that they're making a difference, but one person can't single-handedly change it in the way that they can put out curtains. And I guess I'm curious, which of those messages are most resonant with communities, the personal, the community, or the big picture? And are there ways that we should be getting those stories out, or like, what's the right way to be empowering on these different channels?
So Tracy, why I find wildfire research so interesting is that usually from an air quality perspective, we've always traditionally for anthropogenic pollution targeted the source. So we have, scrubbers, we have point source controls, we have emissions controls, we have vehicle standards, and kind of the idea of pollution control has always been, more so from a industry perspective. And thanks to the government, thanks to EPA, I think, those have largely worked. Wildfires is so different because all the interventions that we talk about are at the receptor level. So it's talking about how to safely shelter in place, or what types of masks to wear, or finding clean air centers to go to, or evacuating. And that really, really changes, because I think in terms of behavioral health, we know that interventions are a lot more effective if they're passive, rather than if you have to actually engage someone into doing this. So what we try to emphasize is just taking small steps. And technology has been a wonderful partner for this. So we tell people, when you check your weather, do you ever notice that the AQI is at the bottom? What does that mean? And it's everywhere. I think if you run Microsoft Windows, sorry, Apple users, but it's at the bottom of your screen now what the AQI is. I think there's a plugin for that too. So I think part of that is just small steps. And what does that mean to me? But making that, I think, information a lot more universally accessible has happened. The other thing, and I think Jonathan alluded to this in terms of the 6 Americas, is that different people need different messaging. So we work with journalism and media communication scholars, many of who were trained here, so shout out to Wisconsin again, just to think about what types of messages. And we have, from a recent data set in Colorado, we have folks that know what the air quality is, know what a bad air day looks like and smells like, and they don't care. They want to go on their hikes, they want to exercise, they want to ride their bikes, which is a lot different than a group that we've called the worried well. So people that potentially are healthy, but are very concerned about getting sick. Different from a group that is helping to manage a family member's asthma, or older adult member that might have Alzheimer's and be impacted by the environment. So I think that those targeted messaging opportunities comes a lot with things that are, Coke and Pepsi figured out a really long time ago, right? Who's the audience? And I think that social marketing, I know CDC's been doing that for a long time, really helps us figure out how to channel our data and get it to the people for, actionable, as Shaneeta, that Dr. Johnson mentioned. So it's exciting, but it does require a village, right? It requires a lot of people and getting out of our silos to think about that. And tackling these big challenges is usually beyond the scope of a HAQAST budget, unfortunately. So sorry, I had to put that in there. Sorry, John.
I just want to add to that about, really know your audience and what to convey. I got connected with this local woman, and she's just a very concerned citizen about the lighting condition in many cities. And I was talking to her, and then she actually gave a wonderful talk in the Houston HAQAST meeting back in June. And one thing I never realized is that she found the most important thing to convey in her meeting with city officials is to educate the police, because really the lighting in many communities are driven by the conception that really the more lighting you have, the safer the neighborhood is, right? And that's not always true, because the glare that are brought by high levels of lighting can actually cause traffic accidents, can actually makes it even more difficult for police to patrol the communities. And B, there are other unintended consequences such as health effects. So that's something, without talking to her, I would never thought of, that educating the police is key to the lighting public education, so to speak. So I guess that's a lesson that I learned from those people who actually work in the communities and get interaction with people we don't get to interact as researchers on a daily basis. So again, I just want to bring that up because that's a valuable lesson I learned. And I think it also speaks to what we mentioned before about, really building those relationships with community and knowing their needs.
I'll take a stab at that too. Between the big picture, the community and personal impact, I think a lot of people are in the community because even though they know climate change is happening now, they feel that the impact is going to be greater for the future generations. And so they're thinking about their kids and their kids' kids. And so when they look at the climate change crisis, they want to make an impact for the generations to come. And it's a little more difficult to explain to them it's happening right now. And here's how the pieces in this puzzle fit together. So when we talk about the community, I think we get a lot more buy-in because they're like, this is happening for my kids. This is, I want my grandkids to have a world to love. That really resonates with people.
Finally, I got to ask a couple questions. I actually have two questions. One's for Mitra. I don't know who came up with that dashboard idea, but that was a brilliant idea. Which one? All of them, I have to say, because it cuts that mega issue of the data visualization of messaging to biteable sizes, right? You can easily target a particular audience. I've been contributing to that. I'm very happy. My question is, how do you pick the topic? You go out and scout for topics, or somebody have to approach you to say, I have this wonderful data set. Why don't you make it into a dashboard? How does that happen?
Great question. So I didn't come up with the idea, so I can't take any credit. All I can say is it is really helpful to have that kind of like hyper-focused tool available, and it's publicly available for folks to use as well. As far as picking what we focus on, you can create a dashboard out of anything. So we have chosen so far heat and health and environmental justice. Those are our main dashboards. I think just based on the timeliness of both of those topics and the partnerships that we were able to leverage to build them out. So for the environmental justice dashboard, we also tried to work with users of different diverse backgrounds and lived experiences, including environmental justice communities, to see if the dashboard we're creating is accessible and is as informative as we want for user testing. And then the heat and health dashboard, we have a very tight partnership with the climate and health program. So together we were able to bolster our tools and our abilities to build those dashboards. So I think it's resource availability, partnership availability, and then the timeliness of the topics.
Thanks. One last question. Who wants to take that chance? Or you want to leave it to me? I do have another question. Related to education, actually, Sheryl. A lot of students came to me and said, wow, I'm so excited about this, helping the community to realize the climate concerns, environmental justice issues. How do I start? What do you say to them?
Yeah. I say that's good. And again, I think that just asking them their motivation is really, why? Like, why is this interesting to you? And, just making sure that that's very clear to them. And it's almost a spiritual journey, a vision quest, because I think that there's each of us in this room came to this room from very different pathways, and figuring out how we got all here to discuss is very inspirational. I feel like, there's a lot of, I think we're teaching Gen Z now in college. Is that correct? I'm not a good, thank you. I'm not a great demographer, but this idea, I think that this generation of students, I feel this feels very motivated to correct all the wrongdoing of previous generation. And I think that's a fair motivation. I think that educating them and having good discussions about how to go about it correctly, right? Young, as you said, like, hi, I'm from so-and-so university, I'm here to help, is not the right way to do it, right? So trying to educate themselves on what the issues are in the community, who are the thought leaders on the community, who are the organizations that are working within their community, and how those organizations have built trust and identified the issues is really, really critical. So I think the motivation is good, and we need to think collectively as a community how to steer that motivation and channel it for the greater good as well. But I'm glad that the students aren't corporate raiders that want to slash and burn everything. But but yeah, the next generation gives me hope.
Thanks, Sheryl. Let's give a round of applause for all our